First of all, my name is Teresa Olasvein, and I'll be moderating this session with Bob Newmar. That needs absolutely no introduction. But before we get started, I just really want to thank the teams of the IVIO and the paramedic trials for actually selecting the ERC meeting to present their data. I think it's a huge opportunity for us. On the behalf of the organizers, thank you so much.
All right, so we will go ahead and get started. I think everybody here recognizes that intravenous access for drug delivery during CPR has been a well-established therapeutic modality. And some of you may not realize that intraosseous therapy really hasn't been introduced into guidelines, wasn't introduced into guidelines till 2010. So it's really been less than 20 years where we've actually had that as part of the guideline therapy. And the most recent consensus on science and treatment recommendations from ILCOR, which inform many of the regional guidelines, is that we suggest IV access as compared to IO access as the first attempt for drug administration during cardiac arrest. Weak recommendation, very low certainty of evidence, but maybe after today, we will not be able to say very low certainty of evidence. And then it secondly says attempts at IV access are, if they're unsuccessful or not feasible, we suggest IO access as a route of drug administration during adult cardiac arrest. Again, weak recommendation, very low certainty of evidence. Recent trials looking at different drug therapies during cardiac arrest did reveal that the utilization of IO access for drug delivery is growing across the world, and it becomes even more important to understand the efficacy of IO access versus IV access, and that's why we're here today to talk about a recently published clinical trial and two first time we're going to hear about the two new trials comparing IV and IO access, and hopefully by the end of the session we'll all be clear on what we should do in our systems. So first we're going to hear from Dr. Ying-Chi Ko, the first author on the VICTOR trial, and then we will move on with the other trials afterwards.
Okay, good evening, everyone. I'm Ying-Chi Ko from Taiwan, and it's my opportunity to have this. It's my honor to have this opportunity to share with you the VICTOR trial. And this is my profile. I have no conflict of interest to declare. And for the VICTOR trial, this is a very challenging study, which first ever introduced pre-hospital IO in our country, and made possible by all the collaboration of the unpaid paramedics, citywide hospital, and government in Taipei, as during the COVID outbreak. And this is my outline today, our EMS setting in Taipei, and method, result, and conclusion. So this is an overview of the EMS system in Taipei. Our EMS system responded to more than 100,000 transport per year, and our two-tier fire-based system include 4 ALS team and 41 BOS team. And the study today will focus on patients treated by the 4 ALS team, which was composed of all paramedics. And for the method, and this is the PICOS question. Among patients with non-traumatic out-of-hospital cardiac arrest, is humoral IO being superior to IV in upper extremity in terms of survival to hospital discharge? And the key feature of our study is that this is a study is conducted in a place where IO have never been used before. So this gave us a reasonable basis for a simple head-to-head comparison between the two vascular access and exclusive focus on the upper extremities. And this is also the first IO RCT in Asia. And adult patients with non-traumatic out-of-hospital cardiac arrest were assessed for eligibility. There are 7 main exclusion criteria, such as sign of obvious death, RUSC before intervention, etc. And the intervention of the study was IO and the humerus, and which was limited to 1 attempt, and the comparison was IV in the upper extremity, and which was limited to 2 attempts. And in cases where the initial attempts failed, the patient would be rapidly transported to the hospital, and the paramedic were regulated not to perform alternative vascular access. And this reflects the actual situation before the introduction of IO, and this aspect makes our study design different from the IVIO and PARAMEDIC3. And we use a cluster randomization based on a biweekly basis and randomized into a 1:2 ratio to IO versus IV. And the research assistant would visit the ambulance team in person to update the instruction. And the paramedic would follow the given instructions. So there is some process because there was no IV before. So before the trial, we have held a series of lecture and hand-on courses and continuous training, hand-on practice, and with high-performance CPR. Also in 2019, we held our first ever cadaver lab for the trial-trained paramedic just for the procedure. And after this course, we have continuous refresher training course per month led by the captain of the paramedic. So since July 2020, the paramedic in Taipei has been utilizing IO, and this is first ever in Taiwan and in Asia. So here comes the result part. We say that it is a very challenging study. And however, after the study be published, we identify some issue by the assistance of Professor Lars Anderson. And after reviewing all the dispatch data and the report card from the paramedic, we identify some issues. And first, the third year of the trial execution was not properly conducted by the research assistant, having more IO cluster than we expected. And second, though we use a biweekly cluster, but the cluster period was not exactly 14 days. It might have been shorter or extended. The primary reason was the local frequent COVID outbreak, which make it challenging for the research personnel and the ambulance team to coordinate perfectly. And the trial had been suspended temporarily for 3 months during the COVID outbreak. And after reviewing all the archive report card provided by the paramedic after the resuscitation, there are 38 crossover cases, which was more than the numbers in the publication, and we have corrected them. And because the IO had not yet been incorporated in our digital system, therefore we collect data from several sources, including report card, digital EMS system, and the dispatch center. So there is some data ambiguity arose from compiling these data. And challenging like this is something we had never encountered before, and we hope that bringing up this issue will be helpful to all. So overall, we found the most critical correction needed is the execution of random allocation was not completely followed the initial stated 1:2 ratio. And during the submission, we did not aware of that, and the research assistant did not inform the PI of this issue. Therefore, we sincerely grateful to Professor Anderson's review, allowing us to clarify the details. And after reanalyzing the corrected data, the direction of all results were consistent with the published data with only minor difference below the decimal points. And the trial was initially planned for 2 years, but extended to a third year due to the COVID outbreak and suspension. And we have reported a comprehensive correction document to the BMJ, and the following will be presented in corrected data. And we have to emphasize that the paramedics on site was blinded, and the outcome evaluators in the hospital was still unaware of the intervention assigned. So a total number of 7,780 patients were assessed for eligibility, and 1,732 patients were included in final analysis, 743 in IO and 989 in IV. And this is a patient characteristic, and we have divided into the phase 1, the first 2 years, and the phase 2, the extended third year. And for the vascular success rate in IO was 91.5% and 56.9% in IV. And the drug delivery rate was 88% in IO and 51% in IV. And in terms of the outcomes, there was no significant difference between the primary outcome survival to hospital discharge. And there were also no significant difference in terms of other secondary outcomes, including ROSC, sustained ROSC, and favorable neurological outcomes. And to further interpret the result, we have performed further analysis. First, to clarify the epinephrine effect, we have performed supplementary analysis, and the results show that in our study, the epinephrine was still effective and was more prominent in non-shockable rhythm and short-term outcomes such as pre-hospital RUSC. And this result was compatible with meta-analysis and the PARAMEDIC3 study. And in our per-protocol analysis, the IV group patient had slightly better outcomes, but the trend reversed after adjusting key variables. However, both of these did not reach statistically significant difference. And if we divide the patient in the IV group into further two groups, successful IV and failed IV, we can find that the patient in the successful IV group has higher survival rate. And in these groups of patients, they have higher proportion of shockable rhythm, witness arrest, or other good outcome indicator of cardiac arrest. So it is possible that patient with good condition got a successful IV. And procedure itself is a selection process, and this finding may echo the bias in previous retrospective studies. And our conclusion is that the finding of the clinical trial show no difference in terms of survival when comparing the two vascular access strategy, the humeral IO and IV in the upper extremity in treating patients with out-of-hospital cardiac arrest. And IO could be considered as first-line choice of vascular access. And we have provided the correction data. And please allow me for last few slides to share with you the use of IO in Taiwan. And before 2019, there was no pre-hospital IO in Taiwan. And by 2024, more than 90% of the cities are using pre-hospital IO. To be honest, this is a huge step for us, and we do not take it for granted. And this is the true story shared by a paramedic friend. And he said before the IO, he said, "Doc, to be honest, I would like to give the patient medication and fluid, but the challenging environment combined with my worsened eyesight make me impossible to do so." For us, Victor is not only a trial, it is the key to introduce IO in our country. And it presents us with more opportunity not only for the patient, but also for the healthcare provider who wanted to help. And lastly, I would like to thank you all again for this opportunity to share with you our study result as well as community initiatives in Taiwan. Thank you.
Thank you. Thank you so much, Dr. Ko. We actually will just move straight along with the presentations. So we have Mikael Valentin to present the IVIO results. And we'll have a bit of panel discussion and Q&A after all the three presentations are done.
Yeah, thank you. So, just find this. Yeah. My name is Mikael Valentin, and I'm an associate professor from Aarhus, Denmark. I have no financial disclosures. I am the coordinating investigator and steering committee member of the intravenous versus intraosseous vascular access for out-of-hospital cardiac arrest trial, which we have termed the IVIO trial. In the next 10 minutes, I will present the methods and results for the trial's main manuscript. A sincere thank you goes to the independent funders of the trial. So the IVIO trial was set nationally in Denmark, conducted across all 5 regions, which all have their own EMS system. Denmark has 5.9 million inhabitants, and EMS attempts resuscitation on about 5,000 out-of-hospital cardiac arrests annually. A cardiac arrest is generally attended by a primary ambulance and a physician-manned unit, either by vehicle or by helicopter. And in Denmark, a physician may terminate resuscitation on scene. During the years 2020 to 21, we found in a prior trial of ours that 60% received the drugs intraosseously, while 40% received it intravenously. In Denmark, we can therefore assume that both intravenous and intraosseous access were standard practices in adult out-of-hospital cardiac arrest prior to the current trial. To determine which access was superior, we designed the IVIO trial also based on the background literature presented by Robert. The IVIO trial was an investigator-initiated, randomized, parallel group clinical trial. On-site individual patient randomization ensured allocation concealment. Patients were randomized 1-to-1 to primary attempts at either intraosseous or intravenous access for the primary hypothesis. As a secondary investigation, those in the intraosseous group were further randomized 1-to-1 to either humeral or tibial intraosseous access. The intervention we defined was that they had to do up to 2 attempts with the allocated method. Treating clinicians could not be blinded due to the nature of the intervention. However, selected outcome assessors were blinded. These were the trial's inclusion and exclusion criteria. We included adults in out-of-hospital cardiac arrest with a clinical indication for vascular access during the cardiac arrest. Exclusion criteria were limited to traumatic cardiac arrest, prior enrollment in the trial, or a functioning vascular access at the time point where randomization was possible. The primary outcome was return of spontaneous circulation, and key secondary outcomes were 30-day survival and 30-day survival with a favorable neurologic outcome. Neurologic outcome was assessed by the modified ranking scale. Additional outcomes included procedural outcomes and adverse events, while follow-up interviews also included assessment of quality of life. Follow-up interviews were conducted at 30 days, 90 days, 6 months, and 1 year. The current presentation includes data up until 90 days, while data for 6 months and 1 year is still ongoing and being collected. The sample size was based on the primary outcome of ROSC, assuming proportions of 30% in the inferior vascular access group and 38% for the superior vascular access group. Using an alpha of 5%, we needed 1,470 patients to have 90% power. Patients were analyzed according to treatment assignment, and all analyses included patients who at the time of randomization met all the inclusion criteria and none of the exclusion criteria. Binary outcomes are presented as both risk ratios and risk differences. I will now present the results. We screened approximately 4,600 out-of-hospital cardiac arrests over 24 months. The main reasons for not being randomized were no clinical indication for vascular access or a functioning vascular access at the time of possible randomization. 1,506 patients were randomized, corresponding to 66% of the eligible patients. A few randomized patients were excluded from all analyses because they did not meet an inclusion criterion or met an exclusion criterion at the time of randomization. This was predefined as I presented earlier. We analyzed 731 patients in the interosseous group and 748 patients in the intravenous group. There was no loss to follow-up for the primary outcome of ROSC, while data on 30 and 90-day survival were missing for a total of 3 patients. Approximately 5% did not receive an attempt at vascular access prior to ROSC or termination of resuscitation, although being randomized. Additionally, 2% of patients in the intraosseous group and 9% of patients in the intravenous group received attempts discordant with the allocation within the first 2 attempts, meaning that they were crossovers. Not shown here, the baseline characteristics were well balanced between the groups. Patients were a mean of 69 years old, 70% were male, 81% had the cardiac arrest at home, and 77% had a primary non-shockable rhythm. Patients received bystander CPR in 83% of cases, corresponding to what is also presented for the background population in Denmark. Median response times for the first arriving unit was 7 minutes. First attempt success rates were 85% in the intraosseous group and 61% for the intravenous group. By the second attempt, this went up to 92% for the interosseous group and 80% for the intravenous group. Despite these differences in success rates, we found that the times to successful vascular access and to adrenaline were very similar between the two groups. Displacement rates as reported by clinicians prior to end of pre-hospital treatment were low in both groups. These are the results for the primary outcome. In the intraosseous group, 30% achieved return of spontaneous circulation, while this was 29% in the intravenous group. This corresponded to a risk ratio of 1.06 and a risk difference of 1.6%. Confidence intervals were narrow, and the p-value, not shown here, was 0.49. Due to a hierarchical approach to significant testing, we did not calculate any further p-values beyond the primary outcome. For the key secondary outcomes, 12% were alive at 30 days in the intraosseous group versus 10% in the intravenous group. This corresponded to a risk ratio of 1.16 and a risk difference of 1.6%. Similar results were seen for favorable neurologic outcome. 90-day outcomes were very similar to those for 30 days. Not shown here, quality of life assessed in survivors were also very similar between the two groups. We also predefined 4 subgroup analyses for the primary outcome of ROSC according to initial rhythm, witness of the cardiac arrest, bystander CPR, and sex. There were no signs of effect modification between the two groups. And now I present the results for the secondary analyses of humeral versus tibial intraosseous access. Both methods had high success rates. The median times to successful vascular access were 1 minute faster for the tibial method, although with wide interquartile ranges. Displacement rates were 5% for the humeral group and 1% for the tibial group. 361 patients were randomized to the humeral group and 370 patients were randomized to the tibial group. Not presented here, baseline characteristics were similar between the two groups. Return of spontaneous circulation was achieved in 30% for the humeral group and 31% for the tibial group, corresponding to a risk ratio of 0.98 and a risk difference of negative 0.6%. 30-day and 90-day outcomes are presented in the article. In conclusion, in this Danish national trial of adults in out-of-hospital cardiac arrest, we found no differences in patient outcomes between primary attempts at intraosseous vascular access and intravenous vascular access. This indicates that the effects of drugs given during cardiac arrest likely do not depend substantially on the route of administration. I'm proud to reveal that the New England Journal of Medicine has accepted the main manuscript for publication in the journal. Thank you to all participating clinicians who included patients or participated otherwise, to my co-authors and collaborators. Thank you to everyone at the conference and at the journal who made this present and publish possible. And this article should be available online after this session has concluded. Thank you.
All right, thank you for that presentation and congratulations on an excellent study and your publication today in the New England Journal. So our third presentation will be the third IVIO study by Keith Cooper from Warwick University, presenting the results of the PARAMEDIC3 trial.
Great. So thank you very much for the opportunity to be here to talk about the PARAMEDIC3 trial. I've gone too far already. Perfect. So this, again, very similar question to what you've already heard before, but some important differences which we'll talk about as we go through. In terms of conflicts of interest, the key one here is that the trial was funded by the National Institute for Health and Care Research, who paid money to the organisations involved. The design of the PARAMEDIC3 trial was intended to be straightforward and pragmatic. So ambulances would attend a cardiac arrest. Paramedics who were trained in the trial processes would assess eligibility, and our eligibility criteria were intended to be incredibly straightforward. So any adult out-of-hospital cardiac arrest patient receiving CPR that required vascular access, with the only exclusion criteria essentially being known or apparent pregnancy or a patient that already had vascular access. At the point that eligibility was confirmed, the trial-trained paramedic would open the envelope, which was a sequentially numbered, opaque, sealed envelope, as was used in the IVIO study, and the patient was randomized to either a primary IO vascular access strategy or a primary IV vascular access strategy. What that meant was that the paramedic would have 2 attempts to secure vascular access via the randomized route. If they were unsuccessful within those two attempts, then they would be able to use their discretion as to the route used for subsequent attempts. We intended to recruit 15,000 patients, and that was intended to detect a 1% difference in 30-day survival. Patients were enrolled under a deferred consent model approved by an ethics committee. We did stop early. The reason for that was that we reached the end of our funded period and were unable to secure further research funding. At the point that we made the decision to stop, the trial investigators had no knowledge of the results, were entirely blinded. The trial is registered there. If you want to have a look, you're more than welcome. The key thing I think about the PARAMEDIC3 trial is we were able to bring together 10 ambulance services from across the UK and 1 standalone air ambulance service. So essentially the entirety of England and Wales were able to participate in the trial except for 1 ambulance service. Unfortunately, Scotland was unable to participate in the trial because they have different laws regulating the enrolment of patients that lack capacity in interventional trials. So moving forward to our results, our population was very typical of the out-of-hospital cardiac arrest population. Our median age was 68 years, 64% of patients were male, 79% of cardiac arrests happened in the home, 82% of cardiac arrests had a medical or cardiac etiology, 70% of our patients received bystander CPR, and 20% presented in a shockable rhythm. So this is an incredibly important slide that's worth spending a few seconds on. So the primary hypothesis by which we had for intraosseous being better was that it would enable faster vascular access and faster delivery of drugs in cardiac arrest, predominantly adrenaline. So if you look at this schematic here, you can see, first of all, that the time from call to ambulance arrival was around 8 minutes, a median of 8 minutes in each group. But overall, the median time from call to securing vascular access was exactly the same in both groups at 20 minutes. Intraosseous access did not enable us to secure faster vascular access. Our median time from emergency call to adrenaline administration was 24 minutes. In terms of thinking about our success rates, first vascular access in the intraosseous group was intraosseous in 94% of patients. 4% of those patients ended up with IV as their first vascular access. In the intravenous group, 65% of patients had intravenous as their first successful vascular access, and 33% had intraosseous as their first successful vascular access, reflecting the fact that those patients will probably have had 2 failed IV attempts and then gone over, and then the paramedic making a decision to use IO for their subsequent attempts. We did not protocolize the route of IO. We allowed paramedics to make that decision based on the patient characteristics and the environmental constraints in front of them. We can see here that around 4 out of every 5 patients in both the IV and the IO group where they got an IO access had it via the proximal tibial route, with around 1 in 5 of those patients receiving it via the proximal humeral route. 94% of the patients in the trial received adrenaline. So moving on to the results, our primary outcome was survival at 30 days. 4.5% of patients in the intraosseous group achieved survival at 30 days. 5.1% of patients in the intravenous group achieved survival at 30 days. What that means is that translates to an odds ratio of 0.94, with a confidence interval going from 0.68 to 1.32, so statistically not significant. We also reported there the adjusted risk difference. Moving on to our secondary outcomes, our survival with favourable neurological outcome at discharge, 2.7% in the intraosseous group, 2.8% in the intravenous group. So again, an odds ratio of 0.91 with a confidence interval suggesting that the result was statistically not significant. When we move on to return of spontaneous circulation, the 36% of patients in the intraosseous group achieved any return of spontaneous circulation. 39% of patients in the intravenous group achieved any return of spontaneous circulation. That gives us an odds ratio of 0.86 and a confidence interval showing that that's a statistically significant result. And we find the same with sustained return of spontaneous circulation. So 22% in the intraosseous group, 25% in the intravenous group, so an odds ratio of 0.85 and a statistically significant result in favour of the intravenous route. So in terms of concluding, in PARAMEDIC3, the use of an intraosseous first strategy compared with an intravenous first strategy did not result in higher 30-day survival. Contrary to our trial hypothesis, it didn't reduce the time to vascular access and drug administration. It did reduce the odds of achieving a return of spontaneous circulation. So I'd like to finish by just thanking the patients and their families that participated in the trial, the ambulance services that have established an incredibly strong track record in the UK of delivering this kind of trial, and the people that work for those services that recruited, and the research paramedics that followed them up. Our trial funder, which was the National Institute for Health and Care Research, trial co-investigators and the trial management team, some of whom are in the audience today, and the members of our patient advisory group, our trial management group, our trial steering committee, and data monitoring committee. The final thing to add is that it doesn't end there. We are still collecting data on 3- and 6-month follow-up. They will be presented at a later date. Like with the IVIO trial, we've been incredibly fortunate that it's been accepted by the New England Journal of Medicine. It is now out. If you go to the website, there's lots more information online, but I will conclude there and hand back to our chairs.
Thank you so much, Keith. I think I'll hand over to you, Kate, just to steer us in some panel discussions.
I'm going to start with a question. I think I saw this in both of the trials just published today. I'm not sure about your trial, so I apologize. But the patients that were excluded because they already had IV access at the time of arrival, and I'm just wondering if I'm presuming that's from a different ambulance arriving first that was not part of the trial, and I just wonder if you think that that would have shifted the results in either direction, if those are patients who are easier IV access. I wonder if you think that matters, that data.
So as far as I see that question, and thank you for it, I think so that's actually a question of whether the effect size would be larger if we tested it in a shorter time to successful vascular access. Right now, the research question is not relevant for the primary unit, at least in our country, because they do not have the skill for the IO, which is why we chose not to include, to let them include patients in the trial. I think, as with a lot of other interventions in intra-arrest, it might be easier to detect a smaller effect size difference if we tested it earlier in the arrest.
So thank you. So as you flagged, some patients were excluded from the trial because they had vascular access at the time the ambulance arrived. That was an important proportion of patients in PARAMEDIC3. I think the important thing that we need to reflect on is that, first of all, those patients were essentially patients where a non-trial trained paramedic arrived first, secured vascular access, so by the time the trial trained paramedic arrived, the patient was not eligible for the trial. The key thing here is that ambulances are dispatched based on who is closest. So what we've essentially got is it's not influenced by the decision of the dispatcher. They have no knowledge as to who is trial trained and not trial trained. So I don't think it introduces any bias. It does take out some patients who might otherwise have been eligible for the trial if more paramedics had been trained, but I don't think it influenced our results or the generalizability of those findings.
And in our trial, the patient who got the vascular access before the paramedic arrived, they will be excluded. But we think that in both groups, they are similar because we have two-tier fire-based system, but the paramedics usually do the vascular access thing. So the BOS team do the like CPR or defibrillation. So we have excluded the patient who got vascular access before they arrive. And we have no, because the EMT2, which was the intermediate EMT in our country, was not allowed to use IO. So only the paramedics was able to perform the intraosseous access.
So you seem to be a man down, Kate. I don't know, we could open it up perhaps for a bit of panel between study questions, perhaps?
Sorry, the echo in this room is making it hard for me to hear what people are saying, but yeah, I think I'm the only panelist who's not involved somehow with one of the trials. So I guess I'm interested to hear what all of you think, or anybody else out there too, about, so the current ILCOR recommendation that Bob started by reading was that, I think, if I remember the wording, we suggest that the initial attempt should be IV, unless there's some reason you think that's not going to be feasible. And I'm interested in hearing from people about whether they think any of these trials should change that, because I think you've all, we've highlighted, you mentioned in Taiwan specifically that there was no IO use 5 years ago, and now there's a lot, right? So I wonder what you guys think should happen based on this data.
Yeah, so I think we're working on a meta-analysis of the results now, and as you can sort of expect, it's sort of no difference, of course. And I think for once, actually, within cardiac arrest, because we now have 3 trials, we have a quite definitive answer on this question when it comes to long-term outcomes, 30 days and maybe even longer. We might not be able to exclude very small treatment effects, like 0.5% or 1%, but I think at least for a long time this question is closed, so I think we can say there is no difference in outcomes. The next question is then how should that translate into treatment recommendation and guidelines? And I honestly think that's very hard to do on sort of a global level or even a regional level, because it will depend on the organization. One point of view would be that IVs are usually much cheaper than IOs. So if there's no difference in effect, use the cheapest one. So that would favor the current recommendation from ILCOR to say to use IV first and then reserve IO for situations where you cannot put in the IV. That raises another question, though, that how are you supposed to learn to use an IO if you only use it the few times where you can't put in an IV, and how are you going to use it in other situations, trauma or kids or things like that? So I think it's also reasonable for an organization to say, given that there are no difference in outcomes, we will bear that cost almost as a training of our staff. So I think I would support the current ILCOR guidelines, but I would also respect organizations that decide to use IO maybe as the first-line treatment for cardiac arrest, because I think you can do that with these results. There is a little bit of a signal return of spontaneous circulation, and I think we'll be debating that going forward, but other than that, there's really no difference in outcomes.
So I think if I speak from, I guess, my perspective and the PARAMEDIC3 perspective is that I agree predominantly with the position that you've taken, that generally we should follow the ILCOR guidelines. And I think that the trials actually reinforce that by collectively not demonstrating any difference. And I guess when this is included in the next update, the values and preferences and evidence to decision table will start to pick out some of those implications in cost. From the UK health perspective that's strapped for cash and looking for cost-effective treatments, I think in this context, when you're looking at the cost of an intraosseous needle compared to an intravenous needle, that in some sense there's the same arguments about having practice with intravenous access and intraosseous that we had observed, and I guess part of the reason the trial received support for funding is similar to yourselves. Over half, 60-70% of patients out of hospital cardiac arrest were having the intraosseous route. The return of spontaneous circulation bit, I think the incremental difference in paramedic 2, was relatively, small, but there was a significant difference in return of spontaneous circulation. And I think, that is something that I think, we should, collectively consider as a community about the opportunities that potentially brings to the whole pathway of care. And I guess things that we heard with the paramedic 2 study, that a return of spontaneous circulation followed by somebody then passing away gave relatives an opportunity to say goodbye. In paramedic 2, we demonstrated a high rate of organ retrieval for people that have been resuscitated with adrenaline. So there are both personal and economic, benefits from a return of spontaneous circulation. But, I equally note that of 3, trials, one of the trial, it was the larger, trial showed an effect, the others didn't.
I can maybe come with one more comment on the ILCOR guidelines. So I was part of the systematic review and that sort of led up to those guidelines. And I think there's another valuable lesson here. So most of that guidance was based on observational studies. And it's quite rare we have the opportunity to sort of compare to the truth. And I think these trials combined have answered this question truthfully. I think it's unbiased and pretty precise. And we now know there is no difference in survival. Whereas there's more than 10 observational studies that show that outcomes are much worse with IO. And I think that's a lesson for sort of community in general, that we have to be very careful about interpreting these observational studies, especially for things that go on during a cardiac arrest, because obviously a successful IO might happen after 25 minutes, where a successful IV might happen after 5 minutes, and comparing those two is very, very difficult. So I think we have to be very careful going forward, basing our treatment recommendation on observational studies.
I was just hoping to follow up a bit, Gavin, with your, the paramedic 3 then actually shows a benefit of ROSC. And then the drugs that we're administrating are not super effective. Like, we wish they were more effective. Like, could part of the explanation be that, like, the drugs that we're administering through these routes aren't effective enough to really show the potential of the routes? I mean, do you have any concern interpreting the positive ROSC data?
So I guess the challenge is, there are 2 drugs broadly recommended in current treatment guidelines, adrenaline and amiodarone. I think that there are some specific questions around amiodarone and its lipophyticity and injecting into a bone as to the impact that might have on pharmacokinetics. I think the could we do with more effective drugs? I think, absolutely we could do with more effective drugs. I guess one of the things that, or part of the premise, given that we weren't changing the drugs that were being given, our hypothesis with paramedic 3 was that the intraosseous route would enable drugs to be given more rapidly, and we didn't observe that happening on this occasion. I guess, if we reflect back on the findings from paramedic 2 and the findings from paramedic 3, then in a sense a take-home message from it is that the proximal parts of the chain of survival, early recognition, bystander CPR, defibrillation, is where the benefits are really going to be seen at a population level.
So I did want to follow up on that, on the premise that you brought up, that in theory, or at least some would have believed that intraosseous initial approach could result in earlier drug delivery. And we saw, I think in all 3 trials, if I'm correct, the time to drug delivery was the same. Can you just comment on why you think that is, why it's not, doesn't seem in real practice that you can deliver a drug earlier by trying the intraosseous route first? It seems likely that you would be able to do that.
So I think the thing that people think about when they think about securing intraosseous access is picking up the drill and drilling the needle into the bone. I think there's the bit we don't tend to think about is the other steps involved. including exposing the skin, getting the drill out, finding it, picking your needle, dealing with the fiddly sticker that you have to put on once it's in. So there's a number of steps in that intraosseous process, and I think we tend to think about the complexity of that process and just think about the drilling into the bone. That's quick. I think it's the bits that are surround that that are the ones that take longer. Did you?
Yeah, I think it's important to point out that both trials, as I also heard you say, Robert, I have a little bit hard time hearing it, but as I heard you say that there's no difference in the times to success between IV and IO, which was the primary hypothesis as to why IO should be superior. So I think that was surprising, but also an explanation for the findings. I agree with Keith, there can be differences in preparation time. I know that both our trials had clinicians reporting times, so retrospectively after that the treatment was done, and there is some imprecision in that data. So whether there is a very small difference of minutes, a few minutes, maybe even seconds, I don't think we're able to detect that with the data we have. But I'm not sure that it would actually do a difference for the patients. As to further attempts with the IO, there is also a point that when you use an intravenous access and so we define an attempt as skin penetration. And when you do multiple attempts with an IV access, you might actually just use the same IV access on the same site. And that might be why we at least in our trial, not see the time differences, whereas there's a strict recommendation in the IO that when you actually drilled towards the bone, you have to change site. So I think there is an hypothesis as to why that there actually may be differences in prep time for the two accesses.
And in our trial, we also found that there's no difference between the time to medication. And our trial used the humoral IO, but in the winter time, you wear a lot of clothes, and our paramedic don't cut the clothes directly. They may ask, may I cut your clothes? The family say no, but the doctors say, may I cut your clothes? They say yes. So it takes a little bit more time to take off the clothes to expose the injection site for the paramedics. This is an assumption. Also, in our trial, we have, in the IV group, there's about 40% failure, and among these IO failure patients, they don't have the time to medication. So if you have a successful IV, you can do it very fast. But if you cannot establish an IV, you will have no this time data. So if we analyze these two data together, you can see that there's no difference, and this is my maybe assumption.
So if I could come in to pick up a point that Lars has made earlier, and to also give Ranjit Lal, who's our fantastic statistician, who along with Chenji were the brains behind the trial, and Sarah and all of the colleagues that contributed to the trial. But we knew that Lars was going to be on the panel, and that he has a knack of asking really insightful and challenging questions, and so we brought Ranjit ready to answer them. And I thought you were going to follow the train of thought around the size of the treatment effect, because we set out to detect a 1% absolute difference in 30-day survival. That would have required 15,000 patients, and for the reasons that Keith explained, we stopped at 6,000 patients. But Ranjit and Chen did some more analyses in order to try to determine what the likelihood, if we carried on to 15,000, or carried on further. I wondered if you could bring that in, Ranjit.
Yeah, thanks, Gavin. Yes, indeed, we did. So Chen, who's the other statistician, we looked at this in quite a bit of depth to sort of ascertain whether stopping early and not reaching the 15,000 was detrimental to the trial itself. And we, in fact, found, just looking at some really simple graphs and plotting the rates over time, that the rates actually stabilized very early on. And in fact, that the difference, the effect size, came to a kind of steady state very early on as well. So, and this was also presented to the Data Monitoring Committee as well, which I think with some confidence, agreed with the fact that maybe stopping the trial wouldn't have any detrimental effect. So I think it was a correct thing, and I think the funders also noted that as well as the Data Monitoring Committee. So I hope that helps to answer your questions, Lars, if there was any around that.
We also want to make sure we have time for some questions from the audience. I think I know of at least 1, 2, 3, yeah.
Hi, Phil Chandler from the UK. I'm just curious around the skills gap potential for IV in the UK has been well established for many, many years, but IO considerably less so. Are we confident that there is no effect or negative effect on their IO competence or confidence in the use in the UK?
So I guess the response is that UK paramedics, it's a core skill for them. It's something they're expected to do. It's something they should be able to do. We set out to do a pragmatic trial, which was looking at the impact of randomizing patients to get IVIO on the basis that that IO skill was part of that core skills that they already had. Paramedics, as always, could, if they were part of the trial, seek additional training if that's what they wanted to do to up their skill set. But I think the key thing here is, unlike the Victor trial, we're not introducing IO as part of the trial. It was already established in UK practice. I think it was the same for you guys.
Yeah, thank you for the question. So we actually saw very high success rates for the IO, both the humeral and the tibial. And as I pointed out, we could see that IO access was almost, it was one of the standard practices for out-of-hospital cardiac arrest even before we started the trial. And it has been a part of the local guidelines for almost 10 years. So I think if you want to talk like a learning curve thing, I think that it pretty much plateaued. We saw high success rates both for physicians and for paramedics. And we did, of course, train them in the interventions before the trial.
So I think something we haven't discussed much is also the difference between the humeral and tibial. And we did see a little bit more issues with the humeral approach, which was probably less commonly used prior to the trial. In a very small subset of patients who came in who had survived the cardiac arrest, we did a CT scan of where the IO needle was placed. So if they had a scan anyway, we just scanned that part as well. And actually, of all the tibial IOs we scanned, they were all in place. They were exactly where they were supposed to be. Whereas the humeral, there was, I think, like 20 or 25% that were displaced. A lot of them were also bent. So there is potentially some issue with the humeral, but I don't think it's necessarily a skill issue more than it's simply the fact that the humeral is a little harder and it can easily displace.
I'm pretty sure I saw some more hands further down. Yeah. Where did the microphone go?
Oh, hi. Sorry, I've got it up here. My question is, all of the trials were on out-of-hospital cardiac arrest. And obviously a lot of in-hospital patients have access already. But do you think there might be problems using this data to create recommendations for both in-hospital and out-of-hospital cardiac arrests?
No, I don't think so. I think I can't see why the pharmacokinetics and dynamics of drugs should be different in an in-hospital cardiac arrest patient compared to an out-of-hospital cardiac arrest patient. I think there could be difference in the team composition and skills. And I think it's a very, very small group of patients in hospital who do not have an IV access. We did a in-hospital trial a few years ago, and I think we had one patient who received an IO out of 500. So it is very rare. So it would be almost impossible to do a clinical trial. So I think we're stuck with this evidence for out-of-hospital cardiac arrest, which I actually think is pretty good, specifically for this question.
So I'm Hans Verschuppen. Thank you for your presentations and congratulations on these amazing trials. I have a question on an aspect which can be different between the groups of IO and IV, which is intravascular volume of infusion. I'm not sure if we can regard this as a confounder, but did you measure differences in volume which were given depending on the route?
Thank you for that question. We did not assess that. I want to point out that the trials are randomized and the baseline characteristics were well balanced in both, in all trials actually. So I think even if we measured that, it would be equal between the two groups.
The current guideline says that if you have an unshockable rhythm, you should give drugs as soon as possible. I think these trials give answer that if you give drugs late, like after 10, 15 minutes, then it doesn't matter if it's IV or IO. Can you comment on it?
So we actually gave the drugs quite early when you consider out-of-hospital cardiac arrest. I don't think I've seen data from anywhere that's faster than the Danish system, so we're quite proud of that. So you could argue that even that, the fastest in the world, is not fast enough, and that might be true, but there's not much I think we can do about that. I don't buy the premise that drugs don't work at that time. The PARAMEDIC3 trials by Gavin's group gave epinephrine after 21 minutes, and they saw a tripling, like 3 times as high rate of return of spontaneous circulation. So it works wonders. It's probably one of the biggest effect size we have in medicine. So I think it still works. It might be too late to save the brain, but the drugs still work. But I don't know how we're supposed to get to the patients faster. In the out-of-hospital cardiac arrest setting, it might be different than the in-hospital cardiac arrest setting.
So with regards to the treatment recommendation that was mentioned that, okay, both work. But on the other hand, I mean, we probably agree that, you know, the standard way of giving medication in the pre-hospital setting is going to be IV, because you can't put in an IO in somebody who's conscious. It's probably not going to work. So why would, if we think about practicing, so why isn't it good for the paramedics to practice a difficult IV? Because that's going to be their standard method of managing other patients who are critically ill, but who are not unconscious, where you can even consider the intraosseous needle. Of course, the pediatric setting is different, but as the trials demonstrate no benefit, I would challenge that recommendation to use either one.
Yeah, no, I'm not saying that should be the recommendation. I'm saying you should do IV if you can. I'm just saying that individual organizations might decide if there's the same outcomes that you can do one or the other. You have to remember that both our trial and PARAMEDIC3 trials had IO as a backup in the IV group. So the Taiwanese trial completely said if you cannot get in an IV and IO, just drive to the hospital. But that's not what we did in our trial. So if you failed the IV twice, you were allowed to switch to IO. So that is what we tested. We tested it where it was a backup option. Whether that changed the results, I don't know. So you can argue whether you should just get rid of it or you should still have it as that backup option, and then you can use it in cardiac arrest or potentially in other situations as well.
I think we'll take one last question.
Thank you very much. Really great overview. Thank you for this. My question is to do more with the humoral route. The initial study that we had the review on was very much focused on the humoral route, and the PARAMEDIC2 study, I think, or PARAMEDIC3 study included 17% from the humoral route. And we do know that with the humoral route, drugs get administered into central circulation quicker. And you did some initial presentation on that from the IVIO study. And I just wondered with the PARAMEDIC3 whether there was any further evidence that if potentially the humoral route had been more in higher percentage, whether that may have made a potential impact on the significance overall.
So we are planning some further work comparing IO route. The key thing to remember about PARAMEDIC3 is we didn't randomize the route, so the best evidence we've got for humeral versus tibial comes from the IVIO trial. That should be the thing that sets our expectations and sets our understanding of it, and they found no difference. And I think we often think that I think there's a perception that tibial route is quicker, but it comes at the expense of potentially longer time to drugs to reach central circulation. Humeral head might take longer to secure, but then the drugs may reach the central circulation quicker. None of those trials tested that hypothesis about central circulation and time from drugs to reach there. So I think we've got the answer from the IVIO trial. There will be some PARAMEDIC3 data coming out at some point exploring that. But I think we need to be careful about making assumptions that one IO route may be better than the other.
Yeah, just to follow up on that, I think for return of spontaneous circulation, the outcomes are almost exactly the same. The confidence interval is quite tight. And if you read the paper, you'll see there are, of course, also other outcomes, 30 days survival, 90 days survival, and if anything, they all point towards tibial being better than humeral. So I think it's very unlikely that the humeral route is better than the tibial route. There's also issues with displacements. It takes maybe a little longer to place. Previous studies has also shown it takes a little longer. But we brought it in because we thought we were going to get that exact question if we'd only done tibial. So we're happy we have it in there, and there's much more detail in the manuscript.
Okay, I think our time is up. Again, thank you so much to all the presenters, in particular for the IVIO and the paramedic giving us a world premiere for the very exciting data we've been waiting for. Thank you so much, and thank you so much to all of you that stayed on so late.